All right, we are recording. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance and policy selects who gets left behind. Welcome back. Today, we're not talking about one outbreak. We are talking about a pattern. And once you see it, you can unsee it. Steep surging, strep surging in children, measles becoming endemic, and the multi-inflammatory system, MISC, is still killing unvaccinated children. An executive order quietly rewriting the childhood vaccine schedule, and a global health community pushing forward on Ebola vaccines. While the country that used to lead that charge is busy building quarantine facilities on foreign soil, but getting blocked by Kenyan courts. So these are not unrelated headlines. They're all the same headline dressed in different clothes. So let's read them together. First, let's talk about strep. It is back and it's harder than before. So pediatric invasive group A streptococcus, or what's referred to as IgAS, or just GAS, or group A strep, is back and it has come back swinging. All right, so a new study in clinical infectious diseases tracked children from 2004 to 2023. Pre-pandemic, group A strep was stable at roughly 1.9 cases per 100,000 during COVID, when masking, school closures, and social distancing were in effect. That rate dropped to 0.6, so from 1.9 to 0.6 by 2021. Think of that as a baseline strep incidence falling about 2/3 almost overnight. Then we reopened everything, stripped away mitigation layers, and told people COVID was over. By 2023, group A strep incidence hit 4.4 per 100,000. That's more than twice pre-pandemic level. For context, 4.4 per 100,000 doesn't sound dramatic until you realize that 88.7% of those children were hospitalized, 34.8% required ICU admission, and 3.4% of them died. So ICU admissions climbed almost 30% in 2011 to 40% in 2023. So these are sicker children, and they're getting sicker faster. Here's the policy thread. The immunity debt we racked up during COVID was predictable. Experts warned about it. The immunity debt framing was used, ironically, to justify reopening faster, as if the cure for disrupted immunity was immediate re-exposure with no safety net. There's no ramp up in pediatric ID resources. There was no enhanced surveillance. Just open the doors and see what happened. And what happens were the results of the study. So let's go to the multi-system inflammatory syndrome in children, also known as MISC. And so what this is, if you remember, one of the more alarming discoveries of the COVID-19 era. It's a rare but severe immune overreaction that shows up weeks after SARS-CoV-2 infection, mostly happens in children who seem fine even when they were sick. But a new study, also in clinical infectious diseases, looked at the MISC, the multi-inflammatory syndrome in children, cases in 2023 and 2024. Good news first, overall incidence is that it's falling from 141 cases in 2023 to 82 in 2024. Okay, now the part that should make every pediatrician furious is that almost 80% of all MIS cases over that 2-year period occurred in vaccine-eligible children who received 0 doses of the COVID vaccine. All 4 children who died during the study period were unvaccinated children. Every single one of them. That's not ambiguous. That is not a nuanced, the science is uncertain story. This is a vaccine that works, protecting children from a rare but potentially fatal complication. Those children are not getting that protection. Why? Because we've spent 3 years, from misinformation on social media to confusing federal messaging to pediatricians who just stopped recommending COVID vaccines because they don't want the argument, systemically eroding the infrastructure of routine childhood vaccination. And the most vulnerable kids are paying for it with their lives. Okay, so let's shift over to the executive order that should have every front page coverage. Last Friday, the president signed an executive order directing the CDC and the ACIP. If we have an ACIP, we don't know. That's the the Committee on Immunization Practices to review the entire childhood vaccine schedule based on a Health and Human Services assessment of childhood vaccines. That order specifically says that the review should consider flexibility for doctors and parents and shared decision-making for vaccines like flu, rotavirus, hepatitis A and B, some meningococcal vaccines, and RSV. Okay, let's tear this apart. Flexibility and shared decision-making, that sounds reasonable, but they're not buzzwords. Let's be clear about what this means in practice. When you move vaccines from recommended for all children to discuss with your doctor, you're removing the standard of care default. The default flips from vaccinate to ask questions first. In a world where misinformation is the ambient background noise of pediatric healthcare, that default matters enormously. We now have 2,000 cases of measles in the US this year, tracking to potentially exceed last year's total of 2,288. Utah has been in an active outbreak for 11 months. Buckingham County, Virginia, has had a measles vaccination rate of 84.9%, so 85%, well below the 95% threshold needed for herd immunity. And Pennsylvania, 38 cases and still climbing. And at the same time, the US this week has no functioning ACIP, no standing federal advisory board or a body to recommend this fall's COVID vaccines. And the dominoes are just wobbling. And into that vacuum, the president just signed an order telling us to make vaccines more optional. This is not policy disagreement. This is policy failure engineered in real time. And the children in those Utah and Virginia and Pennsylvania communities are the ones who will bear the weight of it. Let's go global. Let's flip the camera overseas. Let's talk about Ebola, Kenya, and the geopolitics of who matters. So as we know, Bunju Ebola outbreak in DRC and Uganda continues. The Coalition for Epidemic Preparedness Innovations just committed roughly $60 million to Moderna, Oxford Serum Institute, and the IAVI to accelerate the Bunju vaccine development. That's real money, that's real urgency, and that's real global cooperation. But here's the contrast. The U.S. government's primary response to this outbreak has been to try to build a quarantine facility in Kenya to hold Americans exposed abroad, not to flood the zone with outbreak responders, epidemiologists, and resources. A Kenyan court blocked that facility last Friday, citing a threat to life and constitutional concerns. Let that sentence sit for a minute. A Kenyan court had to tell the US government that using a foreign country as a quarantine holding pen for American travelers was constitutionally problematic. The IDSA CEO, Dr. Morazzo, said what most ID experts are thinking. The administration appears more focused on keeping Ebola out of the US than fighting where it lives. This is the fortress mentality of public health, and it has never worked. Viruses do not respect borders. They exploit the gap between where response resources are concentrated and where transmission is actually happening. 5 Ebola patients were discharged from treatment centers this week and cured. That works when the functioning treatment, that works when there are functioning treatment centers, when communities trust them enough to seek care rather than staying home and exposing family members, when there are staff and supplies, and there's international support. Those things don't happen by building a quarantine camp in Nairobi. They happen by investing in the outbreak itself. Okay, so let's tie all this together. Let's name what ties all this together. Strep rebounds because we've dismantled mitigation without investing in downstream pediatric infectious disease infrastructure. The multi-inflammatory system in children still kills unvaccinated children because we've allowed vaccine hesitancy to metastasize from a fringe position into an accepted framework for parental choice. The childhood vaccine schedule is under executive pressure to become more optional, just as we're watching the consequence of optionality play out in real time in ICU beds, in outbreak clusters, and in pediatric deaths. And our Ebola response is a wall, not a bridge, because the geopolitical calculus of which children's lives generate urgency has always been shaped by proximity to power. These are not coincidences. These are the predictable downstream consequences of treating public health as a political cost center rather than a social contract. The vulnerable, children, the unvaccinated because their parents were misled, communities with inadequate health infrastructure, patients in the DRC, they're always the margin where policy failure lands first and hardest. And until we decide as a society that public health is a floor and not a ceiling, that the baseline standard of care is not negotiable, we will keep reading these headlines and calling them, oh, look at that, we're surprised. But they're not surprises. These are receipts. All right, this is Resistance Radio, where we read the receipts, follow the threads, and refuse to call predictable failures inevitable. Stay curious, stay loud, and make sure your kids are vaccinated, because the best policy argument you can make right now is a fully immunized child. Thank you so much. My name is Mark Allen Derry, and this has been Resistance Radio. Peace out. I got to go to work.